Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody. So guys, everyone, welcome to the class. We'll be discussing the paper number 4 of the May 2024. Okay, let's begin with the first question. It was a question. I don't have only the recall questions with me. So whatever topic is there, I've spoken about that topic, right? So the first one was NIHF. You know that this question was asked long back. It's been repeated now. And non-immune hydrops fetalis causes, they can ask you anytime, but it was asked long back, I think 2016 or somewhere. And then mostly they were talking about this RH isoionization. This answer, except for RH isoionization, everything else is included in this. Okay, so it is we're going to be listing the cause of non-immune hydrops fetalis. That means what do you have here? You have pericardial effusion, pleural effusion, ascites, generalized skin edema. So what are other causes of this particular problem? Now, all my students who are there in the class right now can also keep answering in the chat room. Like I said, how you enter the chat room is by going onto the main Telegram channel. I usually post that Telegram channel in my WhatsApp when I WhatsApp this class to you. I usually post the channel. So once you go into the main channel, there are two channels. One is the main channel, one is the chat group. So main channel, you have to join the class. You cannot join it when you're in the chat group. Main channel, you join the class, and main channel only, there is a pinned message. Just click on that and you'll enter the chat room so you can communicate with me throughout the class and otherwise also. So yes, for the causes, I'll just touch upon the causes. Okay, the question was regarding the causes for NIHF. So we have certain cardiovascular causes, the main causes. Usually the ones which cause hydrops or let's say edema, peripheral edema in adults are also the reasons why they will cause in the fetus, and a couple of them extra. So cardiovascular causes, they cause edema in the adults as well. So congenital heart disease or arrhythmias or cardiomyopathies, they are seen to cause edema even in adults. So the same reasons are there for fetuses as well. Apart from that, you have certain chromosomal abnormalities like all the trisomies. They're responsible for causing, they do cause. Single gene disorders like Gaucher's disease, Niemann-Pick's disease, they cause non-immune hydrops, and skeletal dysplasias like achondrogenesis. Okay. Then hematological cause you must be knowing, anemia in any form, right? Because of parvovirus, alpha thalassemia, twin transfusion syndrome can cause the hydrops, right? Then you have certain infections, CMV. Apart from parvovirus, you have CMV, toxo, syphilis, rubella. They are all causes for hydrops, and obviously all of them are non-immune because immune hydrops is through the RH isoionization, correct? Then thoracic causes like CCAM or chylothorax. Okay, everything is there in the PPT. The PPT will be shared with you. Okay, so everyone who's attending the class, almost all of you already have my paper discussion or the answer bank. Almost all of you have. So that, which is why you already know that the moment the class is over, you get the class and you get the PPT as well. So for all those students who are not able to attend the lecture for whatever reasons, the lecture will be automatically uploaded in the answer bank, right? Lymphatic disorders, you have primary lymphatic dysplasias, placental cord abnormalities, like I just said, twin transfusion syndrome, placental tumors like chorioangioma. These are all reasons for non-immune hydrops fetalis. And believe me, guys, I have given you so many so that you will at least remember 5 of them. And if you write down 5 also, you'll get marks. But remember to write down the first 5, okay? Because it's in decreasing order of, incidence. Then certain conditions like, maybe preeclampsia or poorly controlled diabetes, severe anemia, they might be rare reasons of non-immune hydrops fetalis. So how will you evaluate a case of non-immune hydrops fetalis? How do you manage this case? So mostly remember, guys, that if you know the cause, you can manage it. Apart from that, you'll have to be very, very subjective, and you'll have to probably go more conservatively for non-immune hydrops. Of course, you have to first delineate the cause, preferably. Because then in that case, you can, counteract that cause and can extend the pregnancy. So first of all, most important is a detailed fetal ultrasound, right? So at least 2 more features have to be there to be called as hydrops. Either there should be pleural effusion and pericardial effusion, or ascites along with it, or skin edema more than 5 millimeter thickness, polyhydramnios or placental thickening. 2 of these features have to be there to be called as hydrops fetalis. So after this, since you're doing the ultrasound, you know that this is a hydrops baby, you immediately go forward and look what? You go and see for, of course, the amniotic fluid pockets, you see the placental masses, and you then go and see the MCA PSV, whether the baby is anemic or not. And then, of course, you search for all possible congenital abnormalities, even looking for cardiac arrhythmias and for scan of the heart. baby, the heart of the fetus. Of course, then you have to talk about maternal history, clinical examination. You need to know about what there was any maternal infection in the recent past or certain chronic diseases the mother already has. What was the previous pregnancies? Did she have a similar condition there? What is the blood group? Obviously, that you want to delineate first. Then whether she has had exposure to any infections, parvovirus being the topmost on the list, CMV and tox also coming in third and fourth. Then you go in for an extensive maternal blood testing. You see if mother is okay. You go for a full blood count, TOD screening, parvovirus screening. Okay. And then, of course, you want to go for complete fetal echocardiography, fetal genetics testing, because obviously all these conditions like trisomies or amniotic fluid for infection, the hemoglobin level anemia, you need to get through fetal blood, right? You need to see the genetic testing for all these trisomies, and you want to go in for infection testing for all the infections, and then hemoglobin levels, because you're still thinking whether it's anemia or not, because parvovirus will cause anemia. Anemia is being caused in the fetus, but it's not because of Irish isoimmunization, it's because of CMV or toxo or parvo mostly. And then placental evaluation, of course, through ultrasound mostly. Placental mass like chorioangioma, they are responsible for the cause. So how will you manage? Again, over here, guys, how will you manage it depends upon the cause. So if the cause is, let's say, an infection, you treat the infection. If it's anemia, you treat the anemia by giving intrauterine infusion. See, these infections are causing what? All these infections together, CMV, toxo, parvo, alpha-thalassemia is actually responsible for hydrops. Why? Because the baby is developing anemia. So we cannot fight with the infections because most of them are viral infections, but we can still manage. We can still manage this baby for anemia. So there is a possibility of giving the baby IUT, intrauterine transfusion. And for that, we have already spoken in length when I was discussing about isoionization case discussion with one of my students. We spoke in length what is the dose, how to give, what different modalities of intrauterine transfusion are there, and how to go about it. But intrauterine transfusion is a way to manage hydrops in case the baby is anemic, and because of that the baby is having hydrops. If the baby is having arrhythmia, give antiarrhythmic medications. If the baby is showing some congenital heart disease, well, in that case, you can't do anything, but you're at least prepared for an immediate operative intervention after the delivery. So you already involve a pediatric cardiologist. That is one. If there are, any viral infections or bacterial infections, that you will be ready to give the antibiotic therapy. Like in that case, only syphilis and maybe toxo. Antiviral may be for CMV, they're just saying that. And of course, apart from that, most of the cases in which you don't get to a reason for NIHF, you go for close fetal surveillance, serial ultrasound, serial Doppler studies, amnio reduction of risk required, corticosteroid administration, and delivery of the baby, and then probably search for whatever could be the causes. So obviously, such babies will go in NICU, will be followed up for hydrops, involve the neonatologist at an early phase, extensive counseling, counseling and consents, informed consent, timing of delivery have to be discussed. A lot of things have to be discussed. And with that, we finish non-immune hydrops fetalis extensively, covered. Everything understood, everything, all the causes, all the management, the diagnosis, everything has been included. So that next time if such a question comes, even for a part of it, you're able to write down. Is it okay? Now we move forward to the next question. In case you're having any doubts, guys, be absolutely free and frank. Write it down in the chat room. All of us can see, and we can also reply you back. Okay, guys. Now, yes, thank you, Vardha. Very good. I'm very, very impressed with those students who keep writing. You are getting the answers, but if you start writing down yourself, you are going to, gain maximum out of my class. Okay? My class is going to give you the skeleton. I always tell my students to remember the skeleton. Every word and everything you will not be able to remember, so do smart studies. Remember the points, and then you can fit in, some of the other sentences in one of those points. The points cannot be forgotten. And by the end of my class, in this 1 hour, it's jam-packed informative session. Just imbibe as you go. All right. I usually go a little fast, but you can also go a step further to me, and then you'll be able to catch me up, somewhere in the middle of the class. It's nothing new. It's just more organized. That's all I say about my classes. It's nothing new, just a little bit more organized. And once it's more organized, you start remembering, and then at one point in time, you become, your at final level, that whenever management is asked, you start right from history, examination, investigations, and then management. Webinars management, but you're starting right from how you construct the case and go on to that. And that itself will fetch you marks. All right. Then there was a question on biomedical waste. So I started right from, it was asked management and it's important. So first of all, let's introduce what is biomedical waste. Any waste that is generated during the diagnosis, treatment, immunization of human beings or animals, or in any research activities pertaining to biological processes. So this is the definition. And why is it important? Is because it has such a kind of waste. The WHO classifies the biomedical waste into infectious waste, pathological waste, sharps, chemical waste, pharmaceutical waste, cytotoxic waste, and radioactive waste. Okay, I'm sure you'll be able to memorize all of them. So it's infectious waste, mostly the blood, bodily tissues, fluids, cultures. Pathological waste with the organs, tissues, the complete organs and the fluids, and the human tissues. Sharps is very obvious. Chemical is very obvious. Pharmaceutical is drugs and vaccines. Cytotoxic means I'm talking about genotoxic properties, chemotherapeutic agents, and radioactive means radioactive properties. Okay, so remember that this is the classification of medical waste. What about sources of medical waste? So come on, you close your eyes and you start thinking about yourself. What all other sources of biomedical waste? So you have the hospitals, the clinics, the healthcare facilities, the vaccination centers, the laboratories, the research centers, the blood bank, animal research laboratories, veterinary hospitals, health camps, outreach centers. What more can you think of? Everything is there. The sources of medical waste. Just close your eyes and you'll be able to come up with answers, right? Now let's continue. We were discussing about the hazards associated with biomedical waste. So we have just think about it. We discussed about infectious waste, sharps. We discussed about cytotoxic waste, radioactive waste. So obviously they're going to cause the similar kind of problems, isn't it? Infectious risk from the infectious waste, injury from the sharp waste, pollution from almost all kind of waste, chemical exposure from the cytotoxic waste, radiation hazards from the radioactive waste. It's a very, very simple answer. It's just constructed more, in a more organized fashion. That's it. Then how will you do the waste management? Okay, so there are certain steps involved in biomedical waste. Everybody who's working in one of the big institutes, the NIHF accredited, they know that you have to first of all segregate, color code the containers to put the waste first properly. Okay, so usually you use which dustbin? You use the yellow dustbin, okay, or you use the red dustbin, right? So mostly contaminated plastics are thrown in the red dustbin. So all your IV cannulas or your IV sets or those bottles of IV infusion bottles, they're all thrown in the red dustbin. And your gloves and your, the placenta and all the mops and everything which you want to throw, they get thrown in the yellow dustbin, right? And white are for the sharps. And the blue one is for mostly the glass. So those ampules which come in glass, they are going in the blue one. So usually the sisters, they're the ones which use. But the doctors, they're using the gloves and they're throwing away, the pap smears, either the spatula or everything that you can throw in the yellow one. So first of all, segregation is very important. Then collection is very important. Then storage is very important. Then transport has to be proper, because you see that every hospital, if they're having incinerators, that's fine. But all the smaller setups, they usually send their waste for disposal, correct? So waste should be transported in closed containers, should avoid any spill if it is being transported, and then proper disposal. So incinerators, autoclaves, shredding, deep burial, chemical treatment. I'm sure you've read everything when you were doing your PSM. It's the same thing. And there are certain things which can be recycled. So there are safe recycling now options available, and they should be recycled. Otherwise, we'll be, introducing excessive garbage and very, very bad, hazardous garbage for the, planet. Right. So these were the few, the question was regarding the biomedical waste. And I think I've spoken about the kind of waste there is, the classification of waste, right? The sources of waste, the hazards of waste, how to dispose the waste, okay, biomedical waste management. And if you feel like there are 2 more slides on it, the regulations, the international guidelines, and the challenges. You may or may not write it. In fact, whatever I've already discussed is sufficient for the answer. Okay. So that was a 5-mark short note, in which I've already taught you a lot, because it can be repeated in a different format and you are prepared even for that. Now, what do you mean by standard precautions? Can anyone please tell me in the class? What do you mean by standard precautions? Yes, the answer is there in front of you. All I want is to just, for you to just think a little bit more about your, Absolutely. So basic precautions, right? The standard, what do I say, precautions that you would want to inculcate in all the healthcare sectors, on all healthcare workers, to prevent transmission of infection. Because in hospital, who all come? The people who are already infectious, they come for treatment. So you don't want to cross transmit from one patient to the other, the infection. So you have to do certain standard precautions. So hand hygiene is one of them. 5 moments of hand hygiene, alcoholic based rub. It's like in the spinal level of everybody who's been working in one of those, NABH accredited hospitals. To when you enter, you wear the shoe covers. Then you rub your hand with a sanitizer. Every bed has a hand sanitizer. You touch the patient before you use a hand sanitizer. You before leaving, use a hand sanitizer. And by the end of the day, your hands are literally corroded with so much of scrubbing. Correct. Now, then you have, of course, hand hygiene is important. Then personal protective equipment is important if you're managing a case with a lot of infectivity to safeguard the patient and to safeguard other patients you're using. Personal protective PPE was very, very important at the time of COVID, but that does not stop there. Otherwise, also there are certain patients with low immunity level, high infectivity, the septic wards, you can use PPE there as well, especially operating upon such patients. Then respiratory hygiene, cough etiquette, how to cough, how to sanitize afterwards, masks, very important, safe injection practices to destroy the syringes, use a new syringe every time. These are all standard precautions. Standard precautions. You've been dealing with them right from the very beginning. Safe disposal of sharps, very important. Puncture proof containers. Very important is to avoid the needle stick injuries. See, needle stick injuries, single dose vials, right? All these, new and sterile injection every time. Then contact precautions, droplet precautions, airborne precautions, right? Then standard precautions in surgical procedures like sterile gloves, gowns, masks, right? Every time, even in the smaller setups, even with no much, resource setting, they use at least a standard gown, standard mask, standard head mask, the head caps. Then you have to have a catheter-associated urinary tract infection. So you have to have a lot of hand hygiene, absolute asepsis, sterile equipment, and the same is central line associated bloodstream infection. Again, maximum sterile barriers like sterile gloves, gowns, masks, placing central lines, appropriately a new, every time you use a central line, you use a new this thing which goes inside, and the catheter which goes inside, the intravenous catheter, has to be new, has to be sterile, has to be taken out with adequate sterile precautions. Yes, disposable bed sheets, and especially the high dependency units, the ICUs, they have to be very, very strict with the protocol. Change of the slippers is very important. Going inside the ICU, wear the disposable gowns. If you don't have that much resources, at least wear gowns and go, because you carry so much of infection. Every time you go inside an ICU, make sure that they're using a head cap, they're using this thing, foot covers, or at least they are not using their footwear to come inside. They change the slippers. That's very important.